Good morning, everyone. My name is Ajay Rangaraj, and I'm a technical officer at the World Health Organization in Geneva. Let me first begin by saying thank you very much for this opportunity to present a plenary at this wonderful conference in Bangkok. Unfortunately, owing to circumstances beyond my control, I was not able to be present in person to deliver this plenary. However, the organizers have kindly allowed me to present a pre-recorded presentation on advanced HIV disease in the Asia Pacific. And I will try to touch on some of the key issues and perhaps set the stage for the discussions that lie ahead in the days to come in this conference. And I wish you all a wonderful conference and also hope you enjoy the presentation. I don't have any conflicts of interest to declare. So let me first start with what is advanced HIV disease. Advanced HIV disease for adults, adolescents, and children above the age of 5 is defined as a CD4 cell count of less than equal to 200 cells per millimeter cubed, or a WHO clinical stage 3 or 4 event at presentation to care. All children with HIV younger than 5 years of age should be considered as having advanced HIV disease at presentation. The caveat, of course, being that although children younger than 5 years are considered to all have advanced disease at presentation, those who have been on antiretroviral therapy for at least a year and are considered clinically stable shouldn't be considered as having advanced HIV disease and can be considered for multi-month dispensing. Now, AIDS-related deaths are the critical talking point in this global response to HIV. And I think it's important to reflect that while there's been tremendous successes over the years, with over 20.8 million deaths, AIDS-related deaths averted, in 2022, there were still 630,000 people who died from HIV globally. Also, with the critical changes in how the global health architecture is changing in terms of funding availability, how commodities will be available, there's a very high risk of reversal of these gains. And a modeling study that looked at some of the effect of funding cuts in 55 countries. And you can see that all those gains of 20 million deaths averted can very rapidly be reversed. And I think maybe perhaps to start on a somewhat somber note, but I think it's important to set the stage for the world that we are operating in today. New HIV infections continue to be high. We nearly at 1 million a year. And what remains true is that funding for HIV programs is an extremely diverse portfolio, depending on which region of the world you're in or what country you're in. And what's notable is that in the Asia and Pacific, domestic funding plays a huge role in how HIV programs are funded, particularly HIV prevention programs. However, this does not mean that necessarily this is not a cause for concern. While external dependence has declined, the country now has even more burden placed on it to ensure that it can respond to HIV effectively. But also, more generally, the next 5 years is really going to define where we go in the HIV epidemic. Now, when you really look at how these resources are estimated globally and also perhaps external financing dependency, you can see in the circle box, which talks about Asia and the Pacific, there's a number of areas where Asia Pacific relies primarily on domestic funding to conduct HIV-related activities. But for example, the critical gap that you can see here is strategic information, because here knowledge is power and knowledge will empower programs to respond effectively to HIV. And also you'll see why in a few moments about advanced HIV disease. And you can see here that strategic information, around 77%, is dependent on external financing in order to conduct. And I think this is a really critical and important gap. And of course, you can see there are others, but in comparison to, say, Western and Central Africa and South and Eastern Africa, these numbers are much smaller, but still somewhat noteworthy for early infant diagnosis and prevention. This is a quick snapshot of where we are right now in the global response to advanced HIV disease. As I had said earlier, 630,000 deaths. 30% of people globally have advanced HIV disease at baseline. And in inpatient settings, it's often 50% or higher. There was still 187,000 deaths from TB, 112,000 deaths from cryptococcal infection, and close to 1.5 million children living with HIV and 84,000 AIDS-related deaths among these children. And you can see that this is a disproportionately affected population. When it comes to prevalence, advanced HIV disease is very prevalent in Southeast Asia and the Western Pacific, but is often undercharacterized as a public health challenge and is often less detected or often less noted. And you can see here that in these two regions, you have 46% prevalence of advanced disease. This is at presentation to care, and 33% in the Western Pacific. We're talking at least a third or more of individuals presenting to care with advanced HIV disease. What are the main causes of hospitalization now? Because this is the next logical area that we need to discuss. And you can see by some distance, AIDS-related causes remain the predominant cause of admission globally, followed somewhat far behind by tuberculosis, pneumocystis pneumonia, cryptococcal disease, so on and so forth. But I think it's important to note in terms of mortality, TB and crypto often result in mortality. So continuing with the conversation, you can see that even in the CRO, as well as that is the WHO Southeast Asia region, as well as the WHO Western Pacific region, around 40% of people hospitalized are hospitalized for AIDS-related causes, and 68% of people are admitted for AIDS-related causes in the WIPRO region. And when you look on your right-hand side, a recent systematic review that we worked on, we found that the median CD4 is just around 111 or 108, depending in Southeast Asia or in the Western Pacific. And when you look at hospital death, you can see that the meta-analysis of proportion of people who died is 22% in Southeast Asia and around 9% in WIPRO. But overall, ICU mortality remains very high at 46% compared to the overall, which is only 17%. And this really tells you that these individuals who are admitted are coming in quite late, probably with multiple opportunistic infections and probably too late. And then as we find our way through the healthcare system, we need to start thinking about what happens after people are successfully discharged. Now, post-discharge outcomes are very poor in people living with HIV, and data is relatively sparse in the Asian region. In fact, when we did this systematic review, which was published a couple of years ago, there was really such a dearth of data in the Asian region on post-discharge outcomes. But you can see here when we stratified by high income and low and middle income settings, you can see a pattern emerge, which would be largely generalizable in most settings in Asia as well as in Africa, where you have around 18% or close to 19% of the proportion of patients who are successfully discharged are readmitted to hospital. And when you look at the proportion of patients who died after discharge, that number sits at almost 19.5% in low and middle income settings. So this is really a cause for concern when you, for example, were to construct a cascade through somebody who's admitted for AIDS-related causes, is admitted in the ICU, which has a mortality of 46%. Let's say this individual successfully is discharged from hospital. There's probably an 18% or 19% likelihood that these individuals may actually just never go back to their normal lives or make it back into regular HIV care. And I think this is a huge cause for concern and really spurs the need for us to look at how are we actually analyzing and understanding the HIV care cascade today. So maybe breaking down the example with a fantastic example from Thailand, which the Ministry of Health very kindly shared with us last year on a WHO mission. And it's from the National AIDS Program database, derived from 2008 to 2022. You can really see here that causes of death for people living with HIV is still predominantly AIDS-related deaths, and there's a clear geographic distribution in this country. And this is the sort of data that will really help empower HIV programs to respond effectively to advanced disease. And again, here, looking across the strata of CD4, you can still see a consistently high, in fact, a plateauing of proportion of CD4 with that is advanced disease in these cohorts. And again, you can see that when I spoke a bit earlier about the causes of admission and death, and you can see that these are closely mirrored in the Thai context. And I think this is really important to understand that these infections are prevalent everywhere, particularly tuberculosis and cryptococcosis. But it's also worth saying there are sort of emerging diseases such as talromycosis, which has generated a lot of interest and focus in more recent years, particularly in this CRO and Wipro region. We also need to talk a little bit about pediatric advanced disease because I haven't touched on it yet. And I think, again, we are just coming off of the back of recently launching the advanced HIV disease guidelines. And a lot of the research questions we asked were sort of agnostic of population, meaning which we sought to include adults, adolescents, as well as children and infants as part of the question for the most part. And what we actually found was almost nothing. There was shockingly little data available for pediatrics, particularly infants and younger children. And this trend, unfortunately, backs up into what program issues exist, meaning which there's a lack of timely identification of pediatric advanced disease. There's limited or no routine surveillance. Children are often not well linked to care. They have limited or infrequent access to an appropriate weight-based formulation, particularly for DTG, considering that now this is available across a number of weight bands. And essentially, they are lagging behind adults in this treat-all era. And malnutrition, again, forms an important intersectionality along with tuberculosis in this population group. And you can see that there have been tremendous strides made in early childhood survival for children with HIV, but however, there's still some ways to go. How about children living with HIV in Asia? And I did come across a study from 2023 derived from the Treat Asia cohort, I believe it is, where you can really see that there's still a very significant proportion of children that have severe immune deficiency when at baseline or at ART start. And I think this is really, again, part of a larger global trend where children are lagging behind. And this is an older slide, but I felt it was quite important to maybe touch upon briefly, where, looking at data from about 28 countries that show the highest mortality rates, the issue here is that even though they received the under fives, particularly, despite receiving ART, they still had a greater rate of mortality or treatment interruptions between 2021 and 2022. And needless to say, 50% of children are estimated to die by the age of 2 without ART. And of course, there's also studies that found that malnutrition is present at baseline. Of course, this varies from region to region. And also not offering timely TPT to these individuals is also a problem. And again, based on data, you can really see that this is from old PEPFAR data, actually, that looked at 28 countries, and that's what I was talking about earlier. So this is an old slide, but I do have a point, I promise. Access to DTG continues to be a problem, but is a solvable problem. So DTG-based formulations have gradually scaled up over the past 2 years. They're now available across a wide range of weight bands for children. And at that time, they consisted of approximately 62%, that around 62% of ART being provided to children is DTG-based, based on data from 17 countries. This is from the Clinton Health Access Initiative Market Report, I believe from 2023. And pediatric DTG is a favorable formulation. And now this is what the projection looked like back in 2023, where they really estimated that, essentially saying that our best case estimate, because things are quite current, there is a sort of stagnant and downwards trend in both case findings and retention. Pediatric ART coverages in LMICs will only be 69% in 2027. However, this is obviously solvable and could potentially increase to 100%. However, the most recent HIV market report shows the total children on ART has already started to decline. And these are from the report A. The alphabets represent the countries from which the data is derived from. So this is the quarterly total of children on ART. And you can see quarterly new pediatric infections starting to even spike in some countries as well, while declining as well in other settings. But I think the decline is already happening, and urgent action, intervention, and collaboration are critical at this juncture to ensure that children are not left behind in this time when we are reprioritizing how HIV is going to be managed going forward and how we will ultimately reach the global goals. So it's also important to understand how HIV and advanced disease interact with the health system. So the figure on the left is an important figure which talks about the cyclical cascade of care, which really highlights how continuous people's engagement and disengagement from ART is. And I think it's also important here when you look at this diagram, um, how many people who are eligible for CD4 testing actually receive one? What happens to these individuals who disengage? Where do these individuals go? And what happens to these individuals who are hospitalized? What is their cause of admission? And what are those outcomes? And then how do individuals being discharged from hospitals interact with outpatient care and progress towards long-term retention? And with whom does the responsibility lie? And you can see we have partial answers for almost all of these questions, but we don't have a complete picture for any of those questions. And this is a study that on the left-hand side that talks about the reasons for disengagement. I think the reasons are numerous, but I just want to focus on the ones that are in dark red, which are the most common reasons. And some of the most important reasons include social and psychological support or lack thereof, side effects from ART, unexpected issues relating to mobility, caring and social responsibilities. And I think these are all problems that we often forget. And substance use also should not be underestimated, depending on which country you're in and the setting. But conflict with partners. So I think there's a number of reasons why people disengage from care, and a lot of it is beyond their own control. And I think this is something to be paid attention to. And then on the right-hand side is a fantastic graph, is a fantastic chart that was derived from data from the Zambian Ministry of Health, which they recently published on, that traced individuals who were initiated, 150,000 individuals who were initiated on ART. And you can see that only 60% of people remain engaged in care after a year. And you can see what happens to these individuals. Around 2% of these individuals died, 7% transferred, 30% of people disengaged. 17% disengaged between months 7 and 12. Some people were coming in and out, which is 12%, and then only 34% were continuously engaged in care. And I think this is a really sobering graph in some ways, because this is a program that obviously has very high rates of ART coverage, and they're offering counseling, they're doing all the things that need to be done in order to ensure people stay on it. Yet this is where we are today. And there's some more challenges. I think communicating policy change in relation to CD4 is a significant challenge. Is a significant challenge, despite the fact that WHO introduced the first AHT guidelines quite some time back in 2017. So you can see this really talks about how transition of use of one particular test can change over time, but policy and common understanding of it can lag behind. So in 2006, as you know, for many of us who were present at that early period of the HIV response, CD4 was a way of assessing eligibility to offer ART. And of course, those thresholds increased as we move forward right up until 2013. But then it was found that viral load was a highly sensitive and excellent tool for monitoring the response to treatment on ART. So that was introduced sometime in between 2013 and 2015. And in 2016 and 2015, WHO introduced the treat all policy, that is, you treat regardless of CD4 cell count. So again, knowing the CD4 cell count in that context was less important, and also was no longer useful in terms of monitoring response to treatment, although it was not recommended against, but it was just simply stated that viral load was superior. And then in 2016, the definition for advanced disease was introduced, and in 2017, there was a new guideline for advanced disease. However, that has not really materialized in regular practice, meaning which that CD4 was simply abandoned in a number of countries, or the emphasis on doing CD4 dropped off very rapidly. And I think a study from the IDEA collaboration really highlights this issue really well, actually. And you can see how steep the decline is in some countries after that policy change, particularly between 2010 and 2015. And in the Asia Pacific, there was sort of infrequent ups and downs depending on availability. We also saw that the percentage of advanced disease went down, but this is a trend overall. This relates to the fact that much more ART, this reflects more the impact of treat all. However, you can look at where the CD4 percentiles lie, and particularly in the Asia Pacific, it hovers at around 200. But I think it's important to reflect that despite the fact that the Asia Pacific, compared to a lot of other regions, continued to do CD4 testing, still sees a lot of advanced HIV disease because, again, the package of care was not necessarily offered. So this is the WHO recommendation that says that a package of interventions that includes screening, treatment, and/or prophylaxis for major opportunistic infections, rapid ART initiation, and intensified adherence support interventions should be offered to everyone presenting with advanced HIV disease. And this is currently the status of policy uptake of this advanced HIV disease package of care. And you can see that a large number of countries have taken it up. However, implementation is probably half of where the policy lies. And I think this is important to reflect on. So therefore, it's important to reframe our thinking of advanced HIV disease, because clearly we're not doing something right. Advanced HIV disease has long been seen as a sort of orphan or lone or solitary issue haunting an HIV program, with the expectation that just by improving ART coverage, things would just eventually improve. However, we know that is not true, because you can see that advanced disease has been stagnating at 30% at presentation to care for several years now. And viral load non-suppression is a key linking factor to the next point that I'd like to make. Evidence now demonstrates that rates of AHD have been relatively unchanged, even in areas with good coverage. And I think there's a really great example of this from South Africa in the Cape province, where they have very high rates of ART coverage, close to 80%. However, the proportion of AHD rose from 4% to 63% in ART experienced individuals. So this really, again, reflects why we need to maybe question ourselves on whether we're doing the right thing. So you can see on the right-hand side that there is a relationship between high viral loads, advanced HIV disease, and HIV transmission risk in Africa. And I think I cannot thank my colleagues enough with the thinking and brainstorming around this particular piece of work that was recently published, where, there's about 26 million, 26.3. The example here talks mostly about Africa, obviously. But, excuse me. Yeah. So I think it's important to make the connection between new HIV incidents and advanced HIV disease. And these are usually characterized as separate programmatic issues, often not interlapping with one another. Viral non-suppression is the critical key factor that links these two together. So let's say you have viral non-suppression, AHD at presentation. These individuals go through disengagement, cycling in and out of care. This has an impact on the viral load and worsens their immune status. This then subsequently increases risk of onward HIV transmission that drives new HIV incidents, and thus forms a vicious cycle. This issue is then compounded by goal-driven targets, such as the 95s, which is essential when tracking targets towards a greater global goal. However, the 95s do not describe individuals who are doing badly. They describe individuals who are doing well or know their status or are aware of HIV. But that's not the case with people with advanced HIV disease. So advanced HIV disease primarily arises in a core subset of the larger population with high viral loads. There are a number of interventions, tools, and diagnostics that are present in programs today and are at our disposal. This includes improving early diagnosis through there are a number of recommended interventions, rapid initiation of ART, identifying and managing advanced disease with the package of care, long-term viral suppression with adherence support through counseling, reminders, peer relationships, education, and community, long-acting ARVs, engagement and re-engagement in care. We need person-centered services, tracing and support for re-engagement, and so on. And I think there's a number of priorities for future implementation that really are essential in order to drive countries towards the goal of ending AIDS as a public health threat. So to conclude, we need to rethink how this linkage can be made clear in programs, that is between prevention and advanced HIV disease. We have to think about how our care transition is being managed. Are we doing enough HIV testing? Are we doing CD4 testing? Is ART being optimized in specific subpopulations? How are these resources being distributed? Are they being distributed efficiently? And are we using the right tools to scale up? And health systems need to be rethought. Outpatient care and inpatient care are no longer dichotomous issues that are sort of siloed. However, they are one and part of the same healthcare system because people with advanced disease transition in and out of inpatient and outpatient care. So essentially, these two different guidelines that you see here on the left-hand side are the new WHO guidelines on lenacapavir for HIV prevention, for long-acting injectable PrEP. And on the right-hand side, the new WHO guidelines on the management of advanced disease. Both these guidelines are trying to achieve the same goal. And I think all that's needed is a change of perspective. So to conclude, it's not what you look at that matters, it's what you see. And I would like to end by offering a sincere vote of thanks to all the amazing individuals that contributed to the WHO guidelines, the wonderful research that I could share today with you, and those who are working on improving the lives of people with HIV through clinical care, research, and policy. Thank you very much.